of Road Transport and Highways shows that in the year 2022, 461,312 cases of trauma recorded, in which 168,491 deaths occur. This is more than 33% mortality rate. Our average monthly OPD is 300, monthly IPD is 90, and monthly average elective and emergency cases are approximately 40. In academics, we do weekly seminars, case presentations, and journal clubs. On 17 October 23, we celebrated World Trauma Day, and in also 22. We did a CME on 26 October on the blunt trauma abdomen. Our upcoming events are hands-on training on bowel anastomosis by stapler and tendon repair. Now I invite Dr. Rushal Relia, second year PhD resident, to continue the case presentation. Thank you.
Thank you, sir. Good morning, respected dignitaries, teachers, and all my colleagues. Today I am here to present a case of a 36-year-old patient of polytrauma. I'd like to begin with case history first. A 36-year-old male patient, electrician by profession, with alleged history of motorcycle collision with a bus on 14th May 2023 in Ganganagar, Rajasthan. At the time of accident, the patient was unconscious for 1 to 2 hours. There was no associated ear or nasal bleed, vomiting and seizures, and the patient was wearing a helmet. The patient had bleeding from perianal region, an abrasion of approximately 4 to 5 centimeters on left thigh, and other than that there was no remarkable external bleeding present. The patient was taken to a nearby hospital initially. As per available records of the other hospital in Ganganagar, his pulse was 160, BP was 73 by 40 mmHg, respiratory rate 32 per minute, saturation 99% on room air, and temperature 98.6 degree Fahrenheit. His GCS was E4V5M6. Examination findings at that hospital were his abdomen was soft, non-tender, bowel sounds were present, and anal bleeding was present. In lower limb, swelling was present on left thigh and left leg, and peripheral pulses were absent. The patient was given primary treatment in form of dressing and packing in anal region, and an above-knee slab was applied. Patient was transfused 5 units PRBC, 4 units FFP, and 2 units SDP. Patient was then brought to Mahatma Gandhi Hospital after 2 days of trauma on 16th May 2023. For every patient coming to our emergency room, we follow an ATLS protocol, in which A stands for airway with C-spine protection, B stands for breathing ventilation, C is for circulation to stop the bleeding, D is for disability and neurological status, and E is for exposure and environment of body. In the primary survey of this patient, his airway was patent, there was no cervical tenderness, and his saturation was 97% on room air. On breathing component, bilateral air entry was present, and an equal chest rise was present. His trachea was also centralized. In circulation component, the patient's pulse was 91 per minute, BP was 118 by 78 mmHg. A perineal tear injury was approximately present on 4 centimeters from anal verge, which was muscle deep and without any active bleeding. Left femoral pulses was present, and left side popliteal dorsalis pedis and posterior tibial pulses were absent. His pelvic compression test was positive, and EFAST was negative in all quadrants. In disability component, his GCS was E4V5M6 and bilateral pupils were equally reactive. On exposing the patient, his temperature was 37.4 degrees Celsius, left leg was externally rotated, left limb below thigh was cold with blackening, and swelling on left thigh was present. After primary survey, we do a secondary survey which includes head-to-toe examination of the patient along with thorough history taking. The patient did not have any head injury nor any chest injury. On abdomen, we found there was tenderness present on left flank and bowel sounds were present. Upon per-rectal examination, his anal tone was absent and blood stain was present on gloves. Foley catheterization was done from outside hospital with presence of hematuria, and in pelvic compression test was positive. The patient did not have any history of comorbidities nor any previous surgeries. There was no history of head injury, ear or nasal bleed, or any episodes of seizure. There was no history of blood transfusion prior to the traumatic event, and no history of any long-term medicine intake. Nor did the patient have any allergies. So now I would like to summarize the case once again. A 36-year-old male patient of road traffic accident brought in vitally stable condition after 48 hours of trauma. There was no external head or abdominal injury. Apart from the rectal bleeding, pregangrenous changes were noted on left foot with absence of peripheral pulses, and pelvic compression test was positive. So,
go ahead, we go back 3 or 4 slides in which you have mentioned. Just go back. Somewhere you mentioned E-fast. Come to that slide.
There was an injury to the left.
yes, sir.
Explain these 2 last lines. What is the pelvic compression test and what is E-fast negative?
Sir, pelvic compression test is done to check the modality of pelvic bone. In that we compress the pelvis from anterior superior iliac spine, and it is done only once in order to check the patency of the bone. If pain is present or if we feel any compression while doing the test, it is considered as a pelvic compression test positive, and we can.
Fracture of one of the pelvic bones.
Yes, sir. Either a fracture or some abnormality was present. And E-fast is a diagnostic modality, sir, in which we do a point of care ultrasound of the abdomen in any trauma patient to check if there is any peritoneal bleeding present in it or not. It is done in FAST is done in 4 quadrants and E-fast is done in 5 regions. So there we see the right upper quadrant, left upper quadrant, the suprapubic space, pericardial space, and to check the pleural effusion, we see the anterior thoracic view on a sonography machine.
What does it stand for?
Sir, it was negative, means there was. Sir, E-fast stands for Extended Focused Assessment of Sonography in Trauma Patient. Sir, that that finding was for to checking out the circulation component of the patient. So if CCT is positive in the patient, we suspect that there is some circulation abnormality, like if pelvis fracture is there, then there may be bleeding from pelvis. So management of this patient in ER. Continuous monitoring of vitals with multipara monitor is done. IV crystalloid infusion is started with 2 wide bore cannulas of 16 gauge. Blood samples for cross matching and blood investigations are sent. In this case, the pelvic binder was applied and dressing of rectal injury was done. Patient was sent for radiological investigations and admitted in ward for further management. Now I would like to ask the audience that since this is a vitally stable patient, what radiological investigations could be done in this patient? In this patient, to rule out any abdominal injuries, we ordered a CCT abdomen. To rule out any pelvic injury, an X-ray PBH and CT pelvis was done. Ma'am, because in this case there was no fracture, so in order to see the bones and proper anatomy, a CT was advised. Ma'am, we always like to begin with primary investigations first. Yes, sir.
So when you are saying he is hemodynamically stable.
Yes, sir. Okay, sir. For long bone fractures of lower limb, X-rays of left lower limb were advised, and to rule out a vascular injury of left lower limb, a CT angiography was done. Now I would like to call Dr. Palak Dhakar from Department of Radiodiagnosis to explain about the radiological findings of this case.
Thank you, Dr. Rushal. Good morning, respected teachers, respected seniors, and all my colleagues. I will be presenting the radiological findings of this case. This is a skygram left thigh AP view And this is a CT scan sagittal of left thigh sagittal section and a 3D CT reconstruction reformatted image of the left side. In this we can see there is a transverse fracture of the left femoral shaft in the mid 1/3 with the displacement of the distal fractured fragment superomedially. In this CT we can see that the displacement of the distal fractured fragment is posteriorly along with associated soft tissue component and the POP cast. This is a skygram of left leg lateral view showing a comminuted fracture in the upper 1/3 of the tibial shaft and a spiral fracture in the lower 1/3 of the tibial shaft along with soft tissue edema and POP slab. In the left leg, CT left leg scout view, we can see along with the fractures of tibia, there is a fracture in the upper 1/3 of the fibular shaft. This is a skygram pelvic bone and hip. This is a skygram of a normal patient, and this is a skygram of the patient of which we are discussing the case. Can anyone from the audience describe any abnormality on comparing the two skygrams? Yes, as we can clearly see in this skygram pelvic bone and hip, there is gross widening of the pubic bone from the midline, which is known as pubic diastasis or an open book fracture. In this skygram, we can also see in the inferior aspect of the left sacroiliac joint, there is widening of the left sacroiliac joint, but it is not clearly visible on this skygram due to overlying bowel shadows. So now we'll see the CT images for better visualization. This is a 3D CT reconstruction reformatted image of the pelvic bone and hip, anterior view, posterior view and lateral view. In this, along with the pubic diastasis, we can also see there is a fracture of the left sacrococcygeal region of the S4 segment vertebra, in which was displaced anteriorly, as we can see in the lateral view in the presacral region. Along with this fracture, we can also see there is gross widening at the inferior aspect of the left sacroiliac joint, suggestive of SI joint disruption of the left side. Now we'll see the CT abdomen images. This is the axial view CCT abdomen contrast images at the level of bilateral hip joints, arterial phase, in which we can see this is the femoral head, this is the acetabulum, this is the obturator internus muscle, this is the rectum, this is the puborectalis muscle. In this, and the mesorectal fascia outside the rectum. In this we can clearly see there is a rent in the anterior anorectal wall through which the mixed soft tissue density component is coming out, which is likely fluid or hemorrhagic collection extending into the extraperitoneal space from the prerectal region through the perivesical region going till the left inguinal region. We can also see there are bubbles of extraluminal air in close proximity with the soft tissue component, which are suggestive of the perforation of the anterior anorectal wall. In this axial cut CT scan, CCT abdomen taken at the level of bilateral hip joints, we can see that there is a loss of fat planes in the prerectal and the perivesical area. In this video, we can see that there is a tear in the perineum which is extending from the left ischiocavernosus muscle going to the anterior anorectal wall, suggestive of a high-grade perineal tear. Along with this, we can also see that there is fat stranding in the streaks of contrast which are going into the scrotum, suggestive of extravasation of contrast into the scrotum also. In this CECT abdomen axial view taken at the level of bilateral hip joints, we can see on comparison to the right side, in the left side the skin integument irregularity is seen on the skin, which is suggestive of a lacerated wound on the left inguinal region. Along with this, on comparison of the right subcutaneous plane, which is hypodense, there is linear high density streaks in the subcutaneous plane on the left side beneath the lacerated wound, which are suggestive of subcutaneous edema on the left side beneath the wound. In this CCT abdomen axial view, we can see that as the air in the bowel loops appear white, similarly, we can see that the air specks or the air foci are seen between the intermuscular planes of the left rectus abdominis muscle, external oblique muscle, internal oblique muscle. Also, we can see that there are high density contrast in the intermuscular and interfacial planes of external oblique and internal oblique muscles with few air foci between them. On comparison of the intermuscular plane of right lateral abdominal wall to the left lateral abdominal wall, we can see that there are high density thin streaks of hemorrhagic collection in the intermuscular planes of left and lateral abdominal wall. On comparison of this soft tissue on the left side which appears hypodense, on the right side which appears hypodense, we can see on the left side there are high density linear streaks which are suggestive of underlying soft tissue edema. In this axial view CECT abdomen taken at the level of bilateral hip joints, we can see a contrast-filled femoral vein on the right side and contrast-filled femoral artery on the right side. On the left side, the contrast-filled femoral vein shows a tiny filling defect of the contrast, which is suggestive of partial luminal thrombosis of the left common femoral vein. We can also see a mixed density soft tissue with few air foci in the left hemipelvis, which is likely a hematoma which is pushing the bladder towards the right side. In this CT angiography, coronal reformatted maximum intensity projection image, we can see this is the aorta, this is the common iliac artery, this is the external iliac and internal iliac, the external iliac and the common femoral artery. The common femoral artery divides into deep femoral artery giving the deep muscular branches and the superficial femoral artery. In the superficial femoral artery, we can see that there is a complete block in the mid portion which is about 10 to 11 centimeter of the superficial femoral artery, arterial length with distal reconstitution which is through collaterals. In the distal part, we can see there is a faint or reduced flow on comparison of right side to the left side. There is a faint or reduced flow in the distal superficial femoral, popliteal, anterior tibial, posterior tibial arteries. In the anterior tibial artery, we can also see that the flow is attenuated distally. To summarize the radiological findings, we can say there were multiple fractures involving the fracture of femur, fracture of shaft of tibia and fibula, pubic diastasis, disruption of the left sacroiliac joint, fracture of the S4 segment of the sacral vertebra. There was a perineal tear which was extending from skin up till the anterior anorectal wall with extravasation of contrast from the anterior anorectal wall. There was subcutaneous edema and streaks of fluid or hemorrhagic collection in the intermuscular planes of the left lateral abdominal wall which between the internal oblique, external oblique and transversus abdominis muscle. There was partial luminal thrombosis of the left common femoral vein and there was post-traumatic thrombosis of the superficial femoral artery on the left side in the mid portion of about 10 to 11 centimeter. Thank you. Now I will call Dr. Rushal Relia to proceed forward with the case.
In order to manage a patient with multiple injuries, we had charted an operative plan of this patient in which he was about to be amputated above knee, external fixation was to be done and a diversion colostomy was to be made in view of the rectal injury. He was also planned for definitive fixation of pelvis and stump closure later, anal sphincter plication and colostomy reversal. Sir, because of disruption of arterial flow. Sir, the patient had come 2 days later to us and there were...
If the CT angiography shows distal filling and distal blood, there is no reason to amputate.
Sir, clinically there were pregangrenous changes found on it and there were no pulsations below knee. So a plan for amputation was made.
So before you decide to amputate a limb, you have to demonstrate that there is no chance of any recovery whatsoever. Okay, so this patient should have had a revascularization which was pretty straightforward given the large artery, that's the femoral artery, external, the superficial femoral artery which was involved. So fixing that is very easy. If the arterial trauma is around the ankle, let's say, which is usually not possible. But if large vessels, popliteal, femoral arteries are involved, revascularization is pretty straightforward. And amputation cannot be arbitrarily advised. Okay? Thanks.
Yeah, it can. we do microvascular surgery, we can, can reimplant even a digit. So everything is valuable for patient. Yes. Yeah.
Upon obtaining the blood investigations of the patient, we found that the patient was highly anemic. So we had to transfuse 3 units of PRBC pre-operatively and 1 unit intraoperatively. On post-operative day 1 after amputation, diversion colostomy and external fixation of pelvis, we attained a hemoglobin concentration of 9.2 gram per deciliter. Other routine investigations were also sent which were under normal range. Patient's coagulability profile was normal and viral markers were negative. As the patient had come after 48 hours of injury, the patient was advised to undergo amputation of left lower limb to prevent sepsis formation. The patient was also explained about the need to make a stoma.
So in trauma patient, if we don't amputate the limb or revascularize the patient, there may be chances of reperfusion injury.
Nothing happens. Never.
And golden hour is 6 hours, sir, in trauma patient.
There is a technique for that. First, at the time of we first anastomose, then we make a small cut in the vein. So let some blood go out from the vein, or you can even use some fluid. Just get out of it so that all the lactic acid and whatever metabolic products, they'll go away. And then we anastomose vein. It never happens. It is only the a bit technique.
There are a couple things that happen with revascularization.
Yes, they happen, but if we...
I'll tell you what is the deal. So if you revascularize a chronically ischemic limb, if the muscles have been injured, there can be release of myoglobinuria, and that can damage the kidneys. That's a possibility. But we don't cut someone's limb to prevent that thing happening. So actually, if there is a muscle necrosis, you at the same time do, in addition to revascularization, you do fasciotomies, and then you manage if there is myoglobinuria and there is a risk of injury to the kidneys. There are ways of managing that. So amputation is not like you preempt complications. So I'm sorry about this young man, but I feel this was not a good decision.
Excuse me, sir. If muscle is already necrosed, then what is the role of fasciotomy? Muscle is already necrosed.
Muscle is already necrosed, that doesn't mean 100% muscle is necrosed.
Yes. If there is no contractibility in the muscle and there is discoloration and necrosis of the muscle, in my knowledge, the fasciotomy role is only for the compartment syndrome, just to release the pressure and to increase the blood supply to the muscles.
Absolutely. So that is the thing. But even if muscles are necrosed, that doesn't mean that doesn't justify arbitrarily amputating limbs.
I think plastic surgeon can better evaluate this.
After a particular time, you should not anastomose. But now,
discussion after this thing is over. Let's continue with this, and then we can come back for discussion.
With all the consents, the patient was planned to be operated. This was a challenging situation for both patient and the doctors. An intraoperative urology reference was taken and cystoscopy was done in view of hematuric urine present in Foley catheter due to suspicion of left ureteric or bladder injury. Bilateral retrograde pyelogram revealed minimal contrast leakage in left side ureter and a DJ stent of 4 French 26 cm was inserted. Amputation was done at the level of left femur fracture. The broken bone was resected with a jiggly saw and the wound was left open with possibility of bacterial contamination. Femoral artery and vein were noted to be thrombosed and dark, dusky and non-contracting muscles were seen. All major vessels were ligated and electrocauterized to minimize blood loss, and regular dressing of amputation wound was done and debridement of unviable tissue was done. A diversion colostomy was made in view of the rectal injury. A circular incision was made and done at the level of umbilicus, maintaining appropriate distance from pelvic pins of external fixator. Post-operatively, the recovery was uneventful. The patient was allowed clear liquids on post-operative day 2 and soft diet on post-operative day 3. The stoma was functional from day 4. Patient's stump closure was planned 15 days later along with definitive fixation of pelvis. Now I would like to call upon Dr. Akshay from Department of Orthopaedics, who will guide us about their contribution on this case.
Thank you, Dr. Rushal. Good morning, respected faculty members, my seniors and my colleagues. So we received reference from the Trauma and Surgery department, and after examining the patient, these were the positive findings. The pelvic compression test was positive. There was generalized swelling present at left thigh and left rec region, which could be due to the bony fracture or hematoma. There was deformity and abnormal mobility present in the left thigh and leg region, with suspecting of the multiple fracture in the thigh and leg region. The left limb was cold and pregangrenous changes noted on the left foot. We requested for the X-ray pelvis with both hips, the left thigh and the left leg. This is the X-ray of pelvis with both hips, in which we can see that there is pubic diastasis and there is SI joint disruption. Pubic diastasis is seen and there is SI joint disruption. In the X-ray of left thigh AP view, we can see that there is a transverse fracture of the shaft femur and there is segmental fracture of the tibia. This is 3D CT pelvis, in which we can see that there is pubic diastasis and there is SI joint disruption. This is the classification for pelvic injury. So there can be 3 types of forces which can cause the pelvic injury. One is the lateral compression, one is the anterior-posterior compression, and third is the vertical shear type. In the anterior-posterior compression, there is pubic diastasis and there is SI joint disruption. So a patient comes into the category of APC type 3, in which there is symphysis, diastasis and complete disruption of the SI joint. The pelvic injury are the very complex injury with very high chances of bleeding and pelvic hemorrhage that makes the patient hemodynamically unstable. So we have a management algorithm for the pelvic fracture, which includes emergency management, damage control orthopedics, and finally the definitive management. In emergency, we follow the ATLS protocol. After that, we apply the pelvic binder to stop the bleeding. After that, we advise for EFAST and CECT abdomen. In definitive management, we do open reduction internal fixation with plating. Considering other surgical intervention, which themselves was long procedure, and definitive fixation of pelvis is also a big procedure which takes around 2 hours, and we can't afford the further blood loss and risk of infection. So we plan to apply the anterior external fixator to stabilize the pelvis according to damage control orthopedics. Damage control orthopedics states to do as little as possible, but it should be sufficient enough to save the life of the patient. The damage control orthopedics has the 4 phases. The phase 1 is the acute phase, in which we do the life-saving procedure. In phase 2, there is control of hemorrhage by temporary stabilization of the fracture. In phase 3, there is monitoring of the patient, and in phase 4, there is definitive fracture fixation. The external fixation temporarily stabilizes the pelvis and allows access to abdomen and the perineum. After 15 days of the external fixation, we done the definitive fixation to stabilize the pubic symphysis and the SI joint. We applied a 6-hole curved 3.5 mm reconstruction plate on the superior pubic symphysis. On the pubic symphysis was applied for the fixation.
Can you go back the slide? This is what you did in the patient, right?
Yes, sir.
So, like
Sir, this was.
You're telling us theory, but what did you do on the patient?
Sir, we applied the external fixator.
So what is the external fixator? We are not orthopedicians.
Sir, for the stabilization of the pelvis, we applied the external fixator because the trauma team was also going to operate for colostomy and amputation. So we have to temporarily fix the pelvis. So we applied the anterior fixator to stabilize the pelvis.
So this is like a fixator?
Yes, sir. Yes, sir. We insert the ST pins in the ilium, sir, and we have to use the fixator to fix the pelvis, sir.
So you have to elaborate on
yes, sir.
What you precisely did.
Sir, after 15 days, we done the definitive fixation. We put the 3 mm reconstruction plate on the symphysis and the 5-hole and 4-hole 3.5 mm reconstruction plate for the SI joint stability. So these are the pre-operative and the post-operative photos. In pre-operative, we can see that there is pubic diastasis, and post-op we done the reduction of the pubic diastasis, and the SI joint was also stabilized. In post-operative care, sir, after definitive fixation of the pelvic fracture, up to 8 to 10 weeks, we allow the patient for side sitting and quadriceps exercises, and at 10 to 12 weeks, we allowed patient for toe touch walking, and after 12 weeks, the full weight bearing walking was allowed. Now I request Dr. Rushal for further management.
Thank you, Akshay. The patient had an uneventful recovery post pelvic fixation. Regular dressing was done with all sterile precautions, and patient was discharged after 20 days of stay in hospital. The patient came for regular follow-up on a monthly basis for examination of rectal injury, and after rectal injury was healed, which took almost 4 months, the patient was referred to Department of Plastic Surgery for the management of anal tone. Now I would like to call upon Dr. Prakruti Patel from Department of Plastic Surgery and tell us about their management.
Good morning, respected faculty, my seniors and colleagues. Patient was referred to the plastic surgery department with the complaint of anal incontinence. There is a history of colostomy since 4 months. On presentation, patient has a reduced anal tone. There is a colostomy in situ and had a left abony amputation stump. On per rectal examination, the anal sphincter tone was lax, but on command there was minimal gripping was appreciable. Patient had done investigation of manometry, which shows the resting anal pressure is low, but anal squeeze pressure is normal. Our target is to provide enough muscle tone to make patient continent after the colostomy closure. So we have what are our options? The first is the gracilis flap, which can be done unilateral or bilateral, and the second one is the anal sphincter plication. Since the patient has a minimal gripping present, anal sphincter plication was chosen. The anal sphincter is formed by the external anal sphincter, and which is supported by the puborectalis and pubococcygeus muscle. So during surgery, so patient has a perineal injury. Patient came to us after 4 months. So during per rectal examination, there was minimal gripping was present. So
all these are simple bedside clinical findings. They do not tell you the nature, site of injury. Is there a focal tear in the sphincter that needs repair? And then we have to biofeedback and other things to strengthen. Here you are doing a gracilis repair, assuming that there is a global injury.
No, so we did sphincter plication.
Interplication. So you are assuming that the entire sphincter is weak or damaged in a healthy person that is in a following trauma is going to be a focal injury.
So after 4 months, the healing is already proceed. So there is a fibrosis present. So we cannot appreciate the focal tear in the sphincter mechanism.
Well, one would assume, but after you have tested and you can't find it, then I would accept it. But not having looked for it and assuming that we will not find it, so we don't look for it is the problem.
So during surgery under general anesthesia in knee elbow position, the incision given in a gluteal cleft. After dissection, the puborectalis muscle identified and overlapping of the fiber done and plication of the sphincter done until one finger is snugly fit. So post-operative was uneventful. Patient discharged on a third post-operative day. After that, patient was on a weekly follow-up till 1 month, and then at 3 months and 6 months, at which patient shows good anal tone with a one finger snugly admission.
So did you do a follow-up rectal manometry to see what is the external anal sphincter pressure?
No, sir, clinically
and
only.
What is continuance functioning? Is he able to hold or is he able to?
Sir, there is an improvement. Previously, patient was not able to hold. Mucus discharge was present. Now, the frequency of discharge has been reduced.
Is he doing any regular anal feedback, biofeedback?
The perineal exercise, Kegel exercise was advised, which patient was doing regularly. Sir, yes, anal tone is present. Colostomy is still in situ, so colostomy closure is pending. Yes, sir.
Okay, I have a question for Akshay. Can you tell us something more about the nuts and bolts you used in fixing the pelvic fractures?
Sir, it was a 3.5 mm reconstruction plate which we used to strap. So firstly we apply the external fixator. Hello. So firstly we apply the external fixator to stabilize the pelvis, in which the 2 ST pins was inserted to stabilize the pelvis. After that we use 3.5 reconstruction plate which we use to stabilize the pelvic fracture for SI joint and for pubic diastasis, sir.
Why did you procure these and how much does it cost? The internal, what stuff that you use for internal fixation of the bone fracture?
Sir, the plate material?
Yeah.
Sir, it is of SS, sir, stainless steel, sir.
Company कौन सी है? कितने पैसे लगते हैं?
Sir, it is around, sir, 6 to 8,000, sir.
Huh?
Plating cost 6 to 8,000.
Sir, it actually comes in various Indian implants versus imported implants. Indian implants cost roughly around 10 to 15,000. Okay. And imported implants are costly, that cost us around 50 to 60,000 for pelvic fractures.
So can you give me some details later on
Yeah, definitely.
about the companies, local as well as foreign?
Yes. The local company we used in this case is Nebula, and the imported company, the Synthesis, is the most valued company in orthopedic implant of trauma.
Please send me.
Yeah, I will share. I will share you.
Before we go to the next speaker, just come back to the couple of slides where you have shown the anatomy. Small things in presentation should be looked after.
Yes.
This anatomy that you are showing over here is of a female patient. Your
Yes,
patient
sir.
has been male all through. So this pelvic should have been, this image should have been of a male patient.
Yes,
Small things that you must take care of. This for the residents who are going to present later on.
Yes. So now I'll call back Dr. Rushal for further management.
Thank you, ma'am. The further plan in this patient is that the patient is planned for colostomy closure in upcoming days. The patient is now healthy and with help of crutches and prosthetic fitting leg has been able to maintain his regular life again. This is a patient's interview.
मेरे साथ गंगानगर शहर में हादसा हुआ था, जिसके बाद मैं अपना इलाज करवाने महात्मा गांधी अस्पताल जयपुर आया था। इलाज के दौरान मेरी जान बचाने के लिए मेरा एक पैर काटना पड़ा था। महात्मा गांधी अस्पताल के डॉक्टर एवं स्टाफ का मैं बहुत आभारी हूँ, जिनकी बदौलत मैं भी आज इस दुनिया में अपने परिवार के साथ अपनी जिंदगी जी रहा हूँ। महात्मा गांधी अस्पताल के डॉक्टर एवं स्टाफ का मैं फिर से बहुत बहुत आभारी हूँ। धन्यवाद।
The patient has begun rehabilitation exercises and has now been walking on 2 limbs with help of one prosthetic limb. The challenges and hurdles that we faced in this case was that had the patient been brought early, the limb could be salvaged. Dealing with multiple injuries of the body and preventing the patient to go under sepsis, and we wanted to prevent the vicious triad of death and hypercoagulable state in this patient. Our take-home message is very simple. Golden hour is a very crucial time period in a victim of a trauma patient. Management of a polytrauma patient requires a multidisciplinary approach. And as medical professionals, it is our responsibility is that a patient gets correct management or he is referred to the right center. I am thankful to present this CCR. To the Honorable Emeritus Chairperson, Sir, Mahatma Gandhi University of Medical Sciences and Technology Management, Dean and Principal, Sir, of Mahatma Gandhi Medical College and Hospital, the CCR Review Committee, distinguished family members and students, the Department of Orthopaedics, Department of Radiology, Department of Plastic Surgery, and Department of Anesthesia for helping us with the operative intervention of this patient, and last but not the least, the patient and their family members. Thank you.
Just one or two observations. When we talk about a trauma patient, and from the examination point of view for postgraduates, one thing needs to be stressed is you showed the pelvic stabilization by a pelvic binder, but you just mentioned that the patient had come with a slab, right? So that needs to be emphasized, that any patient with a suspected limb injury has to be stabilized, because the first thing that you do is send for an X-ray. When you send for an X-ray, the patient from the trolley is told to shift onto the X-ray machine. If he has a fracture, he'll try and shift on one side and the fractured limb will fall down, so further enhancing the injury. So stabilizing is very, very important. That has to be stressed, although you mentioned. Second thing, after that should have been the psychological involvement in this patient, because he has had an amputation, so he had to be counseled and all those things. And thirdly, when we talk about amputation in Jaipur, we need to mention something about Jaipur foot during the rehabilitative process, right? Sure. Who made the Jaipur foot?
Sorry, sir. Dr. B.K. Sethi.
So if you are here in Jaipur and talking about amputation, you need to talk about Jaipur foot and the person who made it, right?
As far as revascularization is concerned, the criteria has changed for last so many years.
Okay, sir.
Now it is said that you should always revascularize, even if it is a bit late. What happens is, of course, patient may go for amputation, but the level of amputation will change.
Thank you, sir.
In this case, probably instead of above knee, it could have been a below knee amputation.
So I think this case just highlights the complications and the various options of treatment in a patient who has multi-trauma, and also highlights the importance of involving multiple disciplines in the assessment of the patient and in the management of the patient. So patient with gangrene, vascular injury, plastic surgeons, vascular surgeons, orthopedicians, your team, if they all get together, then the outcomes are likely to be different, right? Yes. And in this particular patient, we did see some difference of opinion as regards to the approach. So then again, it highlights the importance of involving a multidisciplinary team, and which is the strength of our institution right at the beginning.
Thank you, sir.
So I think it's been a good presentation, except that we have still not been able to solve the problem as to where the amputation should have been done. And just like we have a tumor board, maybe we can have a board or a polytrauma board which can take a decision on such things. Thank you.
Thank you, sir.